Thank you, Giancarlo. So these are my disclosures. First of all, I would like to thank PK and Dirk for this kind invitation. I'm a vascular surgeon, and so a majority of my cases are long SFA lesions. And if you are looking at the literature, and you look, for instance, at the results with the drug-eluting stents for task CMD lesions, you see that the primary patency rates are doing quite well, as you can see over here. In the single-arm study with the Zilver PTX pre-market, lesion lengths of 100 millimeter were treated. A 1-year primary patency of 86% was reached. If we are looking at the single-arm study complex lesions in subcohort task CND pre-market, in a lesion length of almost 23 centimeter, we notice a primary patency rate at 1 year about 77.6%. If we are looking to the Alcomer study, the Japanese post-marketing study with the Zilver PTX, 14 centimeter mini lesion length, we notice an 86.4 primary patency rate. And then finally, if you look at the paper of Dr. Zeller in a long lesion registry with the Zilver PTX, 19 centimeter lesions, you can notice a primary patency rate of 86% at 1 year. And all these primary patency rates were based on measurements of the peak systolic velocity ratio. And we all know how we are doing this. And nowadays, it's almost accepted that the 2.4, 2.5 cutoff of PSVR rate is more or less 50% restenosis. On the other hand, if I'm looking at my golden standard therapy, the bypass surgery, and here's more specific, the prosthetic bypass surgery above the knee, then there are also several papers available in the literature. And you see quite good primary patency rates at 1 year, like in the paper published in 2009 of McQuaid, where you can see that 86 patients were treated with a bypass surgery, 1-to-1 randomized towards stent grafts, and in the bypass group, a primary patency rate of 77% was reached. A same randomized trial published by Kedora, also comparing to the Viaban, where we noticed in the bypass group 74.2% primary patency rate. Another paper, randomized Dacron versus PTFE above the knee bypasses, 413 patients, and you see that bypass rates were around 72 up to 78% primary patency at 1 year. And then finally, a meta-analysis of Pereira, more than 3,300 patients were restudied, and you see that in the claudicant group, an 85% primary patency was reached, and in the critical limb ischemia group, 76% primary patency at 1 year. But how is primary patency defined in all these trials? I looked at them very carefully, and I've noticed that primary patency was just defined as with the criteria described by Ann and Rutherford in 1997. What are these criteria? Well, first of all, to say a bypass is patent, you have to see a demonstrably patent graft. You have to have the presence of palpable pulses, the maintenance of achieved improvement in the appropriate segmental limb pressure index. And also one of the criteria to talk about patency is the maintenance of a plethysmographic tracing. And then finally, to talk about a patent bypass, it's a direct observation of patency at operation, reoperation, or post-mortem examination. So there is nothing mentioned about measurement of peak systolic velocity ratios. And so, as already was mentioned in previous talks, we are comparing apples with oranges here. And so just to overcome this, we re-looked in our service to 100 patients who had a bypass surgery above the knee, and we judged these patients according to the surgical definition of patency as all open bypasses. So just according to the criteria of Ann and Rutherford, we were dealing with 100 patients patent bypasses. And then if we are applicating the endovascular definition of patency based on absence of binary restenosis with a definition of peak systolic velocity ratios and a cutoff of 2.4, then we had a complete other situation. The 100 open bypasses were, according to binary restenosis definition based on PSVR measurements, just 89% open bypasses. So there were some more 50% or more restenosis rates at proximal and or distal anastomosis. So it is important to compare apples to apples anytime and anywhere. And so let's randomize with the same assessment methods. And this was the goal of the Zilver study, where the Zilver PTX of Cook was compared to bypass surgery, prosthetic bypass surgery above the knee for the treatment of FEMPOP, task C, and D lesions. Here you see the setup of the study, a 1-to-1 randomization in 220 patients, all task C and D lesions, was performed in Belgium, Germany, Italy, and Brazil. 2 arms, Zilver PTX versus prosthetic bypass above the knee. The primary endpoint, absence of binary restenosis or occlusion within the treated lesion in both groups based on peak systolic velocity ratio measurements with a cutoff of 2.4, and also an endpoint without the TLR at 1 year, clinical-driven TLR. Here you see the timeline of the study with assessments at 1 month, 6 months, 12 months, and up to 24 months. And very recently, last week, the enrollment is completed, so 220 patients are included and randomized in this trial. Here you see some of the inclusion criteria. So the patient is presenting with claudication, rest pain, or minor tissue loss, all Rutherford 2 to 5 patients. Stenotic or occlusive de novo lesions were included, and at least the minimum of lesion length is 15 centimeters. Any previous surgery or endovascular procedure in the target vessel is excluded. Perioperative unsuccessful inflow disease treatment is an exclusion criterion. Any planned intervention within 30 days of the study procedure and major distal amputation in the study limb are also exclusion criteria. So here you see some of the preliminary results in 115 patients. Here you see the patient demographics. There were no statistical differences between both groups, between endovascular and surgical group, as you can see over there. Majority were claudicants, although there was also like 20% of patients with non-healing ulcers included. Here you see some data about lesion characteristics, almost all occlusions in both groups. The lesion length is 24 centimeters in the endovascular group versus 26 centimeters in the bypass group. No statistical differences. The only statistical difference is in terms of procedural characteristic, where the duration of the procedure was longer, much longer in the bypass procedure as compared to the Zilver PTX implantation. And here I want to share with you the primary patency rates at 1 year in this preliminary cohort of 115 patients. A primary patency in the Zilver PTX group was reached of 77.4% compared to 67.8% in the bypass group. If you are taking into account the 30 days window, you see a 73.6 versus a 67.8%. No statistical difference, but just based on 115 patients. Based on freedom from TLR rates, at 1 year, again, in this preliminary cohort of 115 patients, you notice an 84.6% in the Zilver PTX group versus a 74.4% in the prosthetic bypass group. So in conclusion, I can say that the Zilver PTX is obtaining outstanding primary patencies also in long and more complex SFA lesions. Patency analysis in these study cohorts are based on the objective peak systolic velocity ratio assessments. Maybe prosthetic bypass results are not that great in terms of patency as we vascular surgeons always considered, and especially when you are using the endovascular-based peak systolic velocity ratio patency assessment. So a randomized controlled trials like the Zilver PASS with the same assessment methods and the same methodologies in both arms are needed to clarify the situation. And the preliminary results in 115 patients in the Zilver PASS show at least a non-inferiority of the Zilver PTX versus prosthetic bypass surgery above the knee. I thank you for your attention.